Hey, ladies and gentlemen, you once again welcome to the Kingdoms podcast. And today I have with me a very special guest. He is Dr. Joseph Okoeguale. This is the very first doctor on the podcast. How are you today, sir?
I'm very fine. Thank you very much for inviting me. I'm actually very happy to be here.
You're welcome. You're welcome, sir. Just before we hit the record button, I was telling you how okay, I was asking about your name, right? So that I don't get to murder your name. It's quite complex, ASAP people, you guys tend to
Okay,
have like some
okay.
complex names. And I saw you're surprised, right? When I told you that my mother is Asan. And that is why
Yes,
my middle
well,
name
it's
is
such a
Iliome.
coincidence. Your mom will know more about some of the few things I will share in this
Wow.
show. Yeah,
Wow.
yeah, quite
Interesting.
an
Interesting.
experience. Yes, it's quite
Interesting.
an
So
experience. Thank
Okwegale,
you.
the
Okoeguale.
wow.
Okoeguale.
That is the
Yes.
man from Egwale.
From the palace. You
Oh,
know,
from
I think I think in those days, the king have an area within the community.
okay.
Oko is actually a person.
Yeah.
From Egwale is where the king lives, resides, the
Oh,
residence of the
oh,
king. So people from that
okay.
area usually follow that name, Okoegwale, the man from the
Wow.
palace. Mhm.
Interesting. So
So it follows
Oko.
like that.
I sound, sir.
Eh,
Obokian.
oh, Bilu.
But yeah, yeah.
Oh, hooray. We are
That's nice.
fine.
So basically, for our audience who do not understand Asan, I was just
Yes,
doing the
yes,
pleasantries
yes,
with him,
yes, yes.
telling him how you doing, sir, and he says he's
Yeah,
doing very
yeah.
well. Opure means there's
We
no
are well.
problem. He's
We are
well. He's
okay.
well. All is well
Yeah,
with
it's
him.
well. We
Interesting.
are
Interesting.
fine.
So, really, how would you describe yourself in a nutshell?
Um, Dr. Joseph Okoeguale. I'm a medical doctor practicing in the tropics. I'm practicing in Nigeria. I'm practicing in a community in Nesa Central Local Government Area of Edo State, Nigeria.
Wow, wow, a man of the
Yes.
sun.
I'm actually a fellow of the West Africa College of Surgeon,
Wow.
a consultant obstetrician and gynecologist at Ura Specialist Teaching Hospital. I have specialized in fetal maternal medicine, maternal-fetal medicine, and then my interest is in infectious diseases, particularly among the very vulnerable population. When I say vulnerable population, I'm talking about the pregnant women, I'm talking about the children, I'm talking about the elderly, and of course, I'm talking about the healthcare workers. So, but I'm the current director at the Institute of Viral and Emergent Pathogen Control and Research. Have you ever heard of Institute of Lassa Fever Research and Control?
I think I've heard of that. Yeah.
Yes, yes. It was formerly named Institute of Lassa Fever Research and Control, but we have long evolved and have moved beyond that. And currently, we are dealing with a couple of pathogens and not just Lassa fever. So
Mm.
it's now renamed as the Institute of Viral and Emergent Pathogen Control and Research, Area Specialist Teaching Hospital.
Wow. This is a researcher, and okay. Before I get to delve into the whole research, the work you do, right? On a lighter note, right? You talked about people that are vulnerable, and in my head,
Yeah.
I was trying to fix myself into the mix. The mix. I couldn't put myself in. And then, okay, let me put myself. I'm elderly. Interestingly, today's my birthday, so I'm feeling like
Oh,
I'm
happy
old.
birthday. Happy birthday from all of us at the Institute.
Thank
On
you.
behalf
Thank you,
of
sir.
myself and my staff here, we are saying happy birthday to you.
Thank you very much. I appreciate it. I appreciate it. So it's
Thank
it's,
you.
it's
Please accept
special,
that
a
from
special
us.
one.
Next time we'll
Thank you
present
very
a
much.
gift to you. Don't worry.
Oh wow, interesting. You can send it. You can send it. I'm still accepting gifts.
All right.
I am
Thank
accepting
you.
gifts.
Yeah.
Thank you, sir. So before I get to delve into the kind of work that you do, because the kind of work you do is highly, highly impactful. you're impacting the communities, you're impacting lives, and not just lives, lives of vulnerable people. But we always like to get to understand the person, right, before bringing a link to the impact that they're making, right? So that actually is a lead up to my very next question. So, what was childhood and growing up like for you?
Well, um, my childhood was quite very fair. I lived in a family of 11 among so many
Wow,
girls,
that's
so many
that's a
girls.
football.
Yeah.
That's a football team. 11.
In fact, we're like a team. We had like 3 boys and 8 girls. You can imagine what it is to live among so many ladies in the house.
Wow.
So
What was
yes,
your
it
number?
was,
What
it
what what,
was,
what
it
number are
was.
you?
Yeah, I was number 7. I was the seventh of 11 children
Wow.
in within our setting. And our growing up was mainly communal. We had so many people to interact with. Although I actually missed that when I entered the medical school, a couple of academic activities took me away from my parents and my siblings. So I didn't have that time, to share that bonding that I actually would have wanted to have, with my siblings. Moving on, just from my period of adolescence to becoming a youth and all that, when I, did my house job, my national youth service call, I've been away from my family. I've actually had the passion of being a medical doctor because right from my childhood and within my community, we had very few medical practitioners, to actually who actually live within our reach. So getting Medicare was quite difficult in my community. So I have always told my dad, yes, yes, I need to be. I have to be, with so much encouragement from my parents, my mom, my dad, they wanted me to actually study medicine at least. And of course, they also wanted me to stay within the community and serve my people.
Oh,
I've had
interesting.
a couple of travels
Oh,
within so many regions in Nigeria, in West Africa sub-region, in America and many other countries I've visited. But I have usually returned back to Nigeria. I've had a couple of training, but I didn't stay back. I had to come back because of the passion I actually have. Um, Not just for the people in my community. I've discovered a broader perspective, not just for the people in my community, but I've discovered that this is actually a unique institution where I work, an institution that the country actually depends on, particularly when we have an outbreak. So I needed to sit back and actually give my best and all my all whenever I'm needed to actually do some things, particularly during period of outbreak of some of these infectious diseases.
hmm. Interesting. So basically, right, the lead up with your life has actually been towards service, right? Serving your community, serving humanity, right? But then I'm trying to find that link, behind that motivation. So who are those people you were looking up to growing up, and who
Um,
inspired you, yeah, to become a doctor?
yeah, my parents actually inspired. My dad was a workaholic. He was an agrarian, so he worked and worked, and I saw that passion first in him. But just moving forward, when I got to medical school, I had a lot of people who were actually very passionate in what they were doing,
Hmm.
particularly in this area, in this my choosing field. Professor Okoeguale was a mentor right to me right from when I entered the medical school. The very first day he called me into the theater, I was still just a medical student. And theater to do what? To attend to a woman who was dying. He had a viral hemorrhagic fever. And the man, I saw him going in. A disease was as dreaded as that was. When I saw him and he came out, I said, yes, there's really something about this guy, probably, So I kept doing a couple of things with him, making some publications. The mentorship started from there. And then I got a couple of other mentorship from very senior colleague, Professor Akbede, had Professor Asugun, I had Professor Okoeguale, and a couple of other mentors in this field, who were able to open up certain areas, which has actually taken me to this point I am. And they have continued to mentor me in that direction. And anytime doing some of the things I'm doing now, I usually appreciate them because they still remain very fresh in my head on how they picked me and, decide to ensure that, I actually get to this level where I am today. So they have
Wow,
actually been
that's
very good in this aspect. Thank you.
wow. So I picked something from what you were saying. You said something about a viral hemorrhagic something something.
Yes, yes, yes,
But
yes,
then
yes.
you doctors, right? You don't get to realize that you guys use a lot of technical jargon, right? A lot of healthcare jargon that us laymen and women. I know a hemorrhage is like non-stop bleeding,
It's
right?
bleeding,
Yeah,
bleeding.
bleeding and stuff.
Unfortunately, the world, Nigeria and the rest of the world are faced with emerging. When you say something is emerging, it means is coming, either coming newly. When you say it's re-emerging, it means it has been there, but it's coming back again. There are a couple of new diseases that just come into like when COVID broke out.
Mhm.
It was looking like a new disease. But you see, Lassa fever has been here with us since 1969. At some period of the year, you have a period of sort where you have a very high number of cases being recorded with a couple of people dying. It happens like this almost every year. The diseases are caused by virus, and one of the end complications is bleeding. So you say viral hemorrhagic fever caused by a virus, usually presenting with febrile illness. Fever means have the person start having very high temperature. The disease being caused by a microorganism, a virus, and of course, leading to bleeding towards the end of the disease. So that's what it actually is. There are a couple of diseases that fall into that category: viral caused disease, viral of viral origin. One of it is Lassa fever. You have Marburg, you have yellow fever, you have dengue fever, a couple of other diseases, But for my center, like I said, we've long moved beyond that. We are not only dealing on the
Not just dealing with those
Lassa virus
ones.
disease alone, but a couple of other emerging viral diseases. Talk about COVID, you talk about Marburg, talk about monkeypox. We have a couple of cases of monkeypox in the world right now. So it keeps coming. The most important thing is you don't even know what is waiting to happen tomorrow. So we have to prepare. We are
These things
working
don't
with
they
the
scare
community.
you?
How well, we have been here when COVID broke out, when a case of COVID was reported in Nigeria. Um, a, a case was referred from one state, a pregnant woman who was already about 36 weeks and was bleeding, was rejected from one particular facility in one state in Nigeria, was brought here, and everybody started running because we really did not understand the disease at that time. But you see, the woman had to leave. So at that point, took the woman to theater. We operated successfully. The woman became well. So that actually gave an assurance that, yeah, this disease is not as deadly as we think. That's when so many people started coming out from, the environment where I performed that surgery to say we can actually manage these people without getting, so scared. So you need to first of all show that leadership, yes, that it is possible, that you can actually do these things without getting infected. You can actually do this and actually save life. So that's how we continue to manage other cases. We had a couple of cases like that. I've operated over 50 Lassa positive cases.
Wow.
And of course, when they see that I'm still alive, they know that yes, it's not as deadly as it is. People work in the Lassa Fever Institute within my facility, and in the past 12 years, none of them have been infected with the virus. They go in there, they work with the patient, they feed the patient, they give drugs to the patient, and they're not getting infected. The people who get infected are the people who come from outside, who do not work in the isolation work, who do not work in the facility. So you can see.
So you can see
So that's
it
enough to
means that
say
your risk
yes.
assessment procedures
It goes
are
beyond just that
very
level of exposure. Yes.
like your risk assessment procedures are actually very, very effective. That's exactly what you're saying. I know you guys use things like your PPE, that is your what we
Yes.
call what's the full meaning of the
Yes.
PPE?
Personal
Protective,
protective
yeah,
equipment.
personal protective
There's a
equipment,
component
right?
which you call infection prevention and control, IPC. To work in this field, you need to have undergone some training, and it's routine for everybody who work in my institution, being a reference center for cases like this. So you have to undergo some of those training. Apart from that, there are a couple of other things you would have done which could help and reduce your unnecessary exposure to these invading pathogens. Yes, we actually do that. But outside that, um, the experience has been there over time. And that's what has actually um, you know, kept us and, giving us the confidence to do some of the things that we do. We actually do a couple of things. Maybe I'll talk about them
Yeah, I actually asked what
later.
that's
Yes,
what
in
it pissed
course of
me.
this discussion.
Yeah, yeah. There was something that was key on my mind before we talk about the key initiatives that you guys are involved in. I
Yeah.
remember how Nigeria was able to effectively combat um, things like COVID, but they were quite impressive with Ebola. Was your
Yes.
institute involved in that Ebola outbreak combat?
Yeah. Ebola viral disease is one of the emerging viral diseases that we have. The last time we had a large outbreak of Ebola viral disease was in 2014 through 2016, and I can tell you my institution was very instrumental in the deployment of technical experts, not just within Nigeria, but in many regions in West Africa sub-region. I remember we, took some members of our team to Sierra Leone, to Liberia, to Congo, to help with diagnosis of these diseases. And like I told you earlier, we can make diagnosis of Ebola in our facility.
Mm.
Apart from making that diagnosis, we can make diagnosis of other viral hemorrhagic fevers. So we went there with so many fronts, with the confidence that yes, we can do a couple of things, and we're able to actually help. We work with the World Health Organization, and then our mobile laboratory has been supported by the European mobile laboratory, being organized by our collaborators from the Benanon Institute of Tropical Medicine in Hamburg, who have been one of our backbone when it comes to making diagnosis of new pathogen in Nigeria. So they have been very supportive in being able to deploy some of this equipment to regions that are being invaded by these new pathogens. So we have done this. We've gone to Liberia, we've gone to Sierra Leone, we've gone to a couple of other areas, not within Nigeria. Deployment of mobile laboratory to some regions in Nigeria is routine for us.
Mm.
If you have an outbreak in Delta State, probably the Federal Ministry of Health will mobilize technical experts and equipment from Iroa to help the situation. Like I told you, we just returned from Kaduna, where we were able to assist the military to triage and manage cases of Lassa fever outbreak. So we help with the outbreak response. That's very routine for us within Nigeria. And when the COVID-19, when we had COVID-19 in Nigeria, I think ISTH was the first federal institution where the diagnosis was actually made. If I can remember, either the first or the second, but while the COVID was being reported in Europe, we already put our kits together because we
Interesting.
knew that
Wow.
definitely Nigeria is one of the most populous country in Africa, and we are very mobile people. So
That was very
definitely
proactive.
we're going to have a case in Nigeria. We have to prepare with our collaborators in the Benano Institute of Tropical Medicine. We're able to put things together, put the diagnostic kits together, and we were able to, make that diagnosis early enough. And this became a hub for COVID diagnosis in Nigeria, in South Senatorial Zone in Nigeria. So
Hmm.
that's what we are continuing to do, and we are continuing to do so and doing it passionately and very well.
It's quite impressive the kind of great work that you guys are doing. Because I, for one, I'm a Nigerian, born Nigerian in diaspora, and I understand how a lot of Nigerians do underestimate or undermine the effectiveness of the government, right, of any government institution, especially when it comes to healthcare. But it's quite impressive to see how you guys have like world-class partnerships, world-class methodologies, world-class risk assessments, procedures, right, that actually help in combating, these viral pathogens, this, emerging diseases. Because when it comes to infectious diseases, the the risk is very high and the margin for error is very, very slim. But you guys are
Very well,
able to
very well,
combat these
very well,
things
very well.
impressively.
Yes,
Kudos, big
yes.
kudos to you and your team, right? But would you like to share briefly, right? Very simple, sometimes, complex solutions, or would I say solutions to complex problems, lie in the simple procedures, right? I, for one, I am a finance professional. I'm an auditor. I'm a chartered accountant, right? But then I'm an auditor. I have audited like a lot of complex organizations, right? However, I understand the concept behind, having proper internal control procedures, right? We have internal control procedures that some of these internal control procedures are so basic, but they actually are effective in keeping the integrity of that institution. So, what would you
Yeah.
say are those very basic, control procedures that you guys have that actually helps the success of your programs?
All right. Thank you very much. I will say that first, we have an organized institute. There are different arms of the institute, which ranging from the administrative aspect, you have the clinical aspect, you have the laboratory arm of the institute. And of course, outside this, there are other subspecialties that are there. Now, these institutes have their own structure. Each of these arms have their heads of units, that ensure the day-to-day running of each of these institutes. Now, coming back to these arms, um, the clinical arm works directly at the isolation ward facility, where you have clinicians and a couple of support staff working with the key clinicians, the doctors, the nurses within the isolation ward. Now, what do they simply do? They have algorithms, they have flow chart, they have standard operating procedures which they work with and which they have to follow. As basic as hand washing is, you can see it, the flow written on the wall, how you will wash your hand to ensure that you don't get infected. As basic as walking through, basic as walking through the isolation ward facility, you have the algorithm there. You don't jump any step. You have to maintain that standard. And we have to keep some people there with primary responsibility to ensure that everyone follows it the way it is. And
Interesting.
apart from that, we keep so many people away from the ward. People can be very emotional when their relatives are admitted into the ward. I haven't seen my wife for several days. He has been kept here and all that. When it comes to infectious disease, and life matters. Try as much as possible to keep emotions out of it. And what makes us very distinct from so many other centers that have similar structure like us is ability to involve all subspecialties.
Hmm.
If a
You
patient
have
develops renal
good
complication,
designs. Like
yes, yes,
it means you have good control designs and you have strict control implementation.
very well, very well, very well. Good control. We have strict measures. We have, those designs are already there.
Hmm.
We have this subspecialty care, which many other centers are really not practicing for now. If I have a patient who has a Lassa fever and eventually develop renal complication, I'm an obstetrician. I will have to call in the renal physician at that point to come in and manage with me. Everyone, every consultant in the hospital in all field of subspecialty are prepared, actually prepared, to handle every case that is related to them. That's why I told you the drills that we do are not just for those at the Institute of Viral and Emergent Pathogen Control and Research. So yes, we are quite, you know,
You're quite proper in what you do. You have properly designed controls, and you also have strict and effective implementation of the controls that are in place. So I think my next question would be, what are the key research projects, and the key initiatives that you are involved in?
okay. Um, Let me mention that the World Health Organization currently have an R&D roadmap, research and development roadmap, which is developing all countermeasures that will help to manage and, of course, totally eradicate most of these emerging and re-emerging infectious diseases. With Lassa fever in focus, our current point of call is to find a way to develop a vaccine. Because I can tell you, the only veritable strategy to kicking out Lassa virus disease in Nigeria is by developing vaccine. There should be a vaccine because at every point of outbreak, people die. Just recently, I can tell you between December and the end of March, we had over 220 new cases of Lassa fever, people being infected. In Nigeria, a case fatality rate of 70% of those who were infected with the disease actually died. You can imagine that. The case fatality can be high. So long you have communities where you have rodents are the primary cause of the disease, where you have
Oh,
rodents,
really?
yes. Lassa fever is caused mainly by rodents called the Mastomys natalensis, major route by transmission of transmission. So long you are having rodents within the communities, Lassa fever will continue to happen.
Hmm. Interesting.
People continue to have the Lassa viral disease. So you can't completely keep the rodents out of the community because you have bushes and a couple of things in the community. You have a couple of houses, where there is poor sanitation, because where
Exactly
rodents
what was in
can
my
breed.
mind. Like, I think people are, sanitization. If people improve on their sanitization and measures, right, so that would effectively
It will help.
reduce
It will help. It will help. But it's actually
cases.
very difficult. And the only veritable strategy still remains developing vaccines and other countermeasures. And we are working with a lot of collaborators. The IRV, working with some friend collaborators, the Coalition of Epidemic Preparedness and Innovation, CEPI, are currently on that road, working with World Health Organization to develop vaccine. In fact, they are currently in stage 2A. Some people are already being vaccinated as one, with some of the trial vaccines
Hmm.
to know how effective before we move to phase 2B. And of course, by phase 3, phase 4, the vaccines would have been, getting to a larger number of people. So I
How many
can tell
phases
you that's
does the
actually our
vaccine need to go
roadmap.
through? How many
Hello?
phases? How many phases does a vaccine need to go through before it becomes
Four
approved?
to five phases. 4 to 5 phases. The preclinical phase, the first phase 1, phase 2, phase 3, phase 4. At the fourth phase, it's already getting into the market. So we are currently in phase 2, phase 2A, phase 2B. Phase 2A, you are just involving fewer numbers of people. Phase 2B, you are involving larger number of people to actually, ascertain the effectiveness of the vaccine. And
Hmm.
some people in Nigeria have already gotten some of this vaccine, and we are happy. We are very happy that we are playing integral role in pushing to ensuring that yes, we are able to develop this, and of course, something that will become very effective for every person living in West African community. Lassa fever has put about over 37 million people living in West Africa at risk of being infected every year. We are recording over 500,000 new cases every year and over 5,000 deaths yearly. So why can't we develop a vaccine to help prevent the disease from infecting the people who live in West Africa community? If this was to be an international disease like COVID-19 was, it didn't take up to a year to develop vaccines
There are
for
more resources
coronavirus disease.
being
It
put
was an
in.
international disease. Imagine, Lassa fever has been with us since 1969. We celebrated 50 years of living with
Oh,
Lassa fever in 2019. And this is 2024. Almost 54 years of the first case of Lassa being infected. It has continued to cause mortality, infecting children, infecting pregnant and non-pregnant adults, infecting the elderly, and many health workers are dying every day from the disease. I mean, we have to do something. That's actually our roadmap. The second is actually on therapeutics. There are a couple of new drugs that we are trying to develop. We are starting with Lassa fever because that's what has been with us for a long time. Finding new therapeutics. The only known drug currently used in Nigeria has not undergone any form of clinical trial, and
hmm.
that is ribavirin, which it has a lot of side effects. How do we make, in fact, before we get the vaccine, how do we make the management better for people? How do we develop new drugs that is very tolerable, that will not cause anemia, that will not have other side effects, that will not be renotoxic, that will not be toxic to the liver? How do we make it better? A couple of such studies are ongoing outside epidemiologic studies. So we are doing seroepidemiologic study, we are doing therapeutic study, we are doing vaccine study. So a lot is on us.
But
And
what
I
is the
can tell
funding
you,
like?
well, you mean funding?
Yes, please, for these projects.
Nigeria generally has very limited funding. I can tell you most the Nigerian budget really do not capture a couple of these things that we do. Fortunately, we're able to have some NGO who are interested, like the Coalition of Epidemic Preparedness and Innovation, being interested in, some of these preventable diseases like Lassa fever. If they key in, we work with them, not for profit making, but actually to develop something that will help to better the lives of people who come down with this disease. That's actually
Are
the
there,
target.
are there like applications to donor agencies, let's say like likes of Global Fund? Because I know I used to
Yes,
work.
global research funds. There's a couple of researches that we do here. Some of them are sponsored by from funds from Global Research Fund, although very small, but some epidemiological studies have been sponsored by them. A couple of laboratory studies have been sponsored by them, but these bigger, vaccine studies are actually large studies. You need
Exactly.
major
And you need
funding for
heavy
vaccines
funding
and
for
therapeutics. And
allergy.
we are currently calling on our federal government to help with a budget line. If the institute has a budget line, we will be able to execute some of these researches. These are some of the challenges we have in Nigeria, and I think there are some of the things the federal government needs to prioritize, which we are telling them, yes, these are important areas, and you need to prioritize this area. And I hope they listen to us, in the coming budgetary allocations and all that. If we are considered, then we could actually do more. But so far, we have had all this from NGO and some agencies like the Global Research Fund, the Benin Institute of Tropical Medicine have been very open. Apart from providing some test kits for some researches, providing support, supporting patients through their investigation, they've been able to champion some studies, some groundbreaking studies, have been done by, our Gemma counterpart. And that's why we really appreciate them when a couple of times, because they have been very helpful in terms of providing this succor, which we haven't gotten from many other areas.
Hmm, interesting. So, basically, there are a lot of people who are vulnerable when it comes to these infectious diseases. But I recollect you are a gynecologist and obstetrician, right? So, just for
Yes,
the layman, a gynecologist is a doctor of women, or is that what is a
yes.
gynecologist? Right?
Gynecologist is for the laymen, like my people, I'll tell them I'm a woman doctor. In Nigeria, if I tell them I'm a woman doctor, I attend to women who are pregnant, I attend to women who have problems with their womb. They understand me better.
Okay. But
Uh-huh.
what's the difference between gynecology and
Yes.
obstetrician? Like,
Obstetrician actually deals with pregnant women,
okay,
whether they have problems or they don't have problems. So long you are pregnant and it's relating to the pregnancy, it becomes an obstetric case.
okay,
But
okay.
gynecology, the women are not pregnant. So for matters relating to the genital tract for non-pregnant women, it becomes a gynecological case.
Interesting.
If you
I hope
have a uterine
I
fibroid, it becomes a gynecological problem, no longer an obstetric problem,
hmm,
because the woman is not pregnant. But you have
okay,
a fibroid in pregnancy, you can have the both going together. You're having a gynecological problem and you are also pregnant. So
interesting.
both of them can happen together.
Hmm,
So in a nutshell, an infertile patient that comes to you is a gynecological patient. You try as much as possible to make the woman pregnant by applying your knowledge and
hmm.
managing her through her infertility. Unlike a woman who has already gotten pregnant, you want to see her for antenatal care and help her to maintain that pregnancy until she has a successful birth. That becomes an obstetrics.
So these
So,
women tend to be very, very vulnerable because
yes,
maternal fetal medicine, right? And then they now have these infectious diseases like I really can't wrap my head around it. Like, how terrible can it be? Like, the risk is high. So, and there's
yes,
also a risk of
yes,
infection passing from mother to child. Why did you
yes.
decide to specialize in this thing? And like, what has been the success rate thus far?
Um, the pregnant patients are very vulnerable group. First, when you are dealing with pregnant women, you are dealing with two life, two people, the mother and the baby. A couple of things comes with pregnancy. A couple of things come with pregnancy, which could be impacted by the change. There are some subtle changes that happen in pregnancy, either the hormonal changes, which is occasioned by the pregnancy, or the changes that occur from the fetal environment itself. Now,
Okay.
there's a communication between the mother and the baby.
Mhm.
And a couple of these pathogens, when they infect the mother, eventually cross from the mother into the baby. And some of these pathogens have what we call sanctuary sites in the body where they like to reside. I will take Lassa fever, for example. A pregnant woman will have a placenta, will have a cord that is connecting the baby to the mother. Now, some of these placenta could actually be sanctuary sites where the virus actually like to reside. So as soon as they enter into the mother, they are transferred into the baby. They reside, most of them reside within the placenta in the mother, which is implanted in the uterus. And of course, what do you have? Because that's a sanctuary site, you can actually have a higher viral load of these viruses within a pregnant patient as compared to women who are non-pregnant.
Mm.
And
So you guys
oftentimes a
handle
higher viral load
deliveries
could
of these
correlate with
women as
poorer
well?
outcome. Okay. Can you hear me
Like
now?
I can hear you. So I was just curious, right? Like these women are highly vulnerable, and then they are
Yes,
at risk because of these viral infections, right? But then when they are within your healthcare system, do you also take delivery, of these women as well? Because I
yes,
also understand that there sometimes can be obstetric emergencies, the likes of shoulder dystocia, breech delivery,
yes.
all of this
A
kind of
woman
things.
is
So how do you
exposed to so many
manage this
people, whether
thing?
in the communities or within the hospital. When a pregnant woman comes in labor, so many people are exposed to the pregnant woman,
Mhm,
from the
mhm,
nurses through the doctors to the support staff. So
mhm.
the risk of infection of healthcare workforce can be very high from a single pregnant patient. So you must try and protect the pregnant woman as much as you can. Because apart from people being exposed to that pregnant woman in the community, they're also exposed to the pregnant woman within the hospital. And the pregnant woman and her fetus are at risk of
Are you guys appropriately
developing.
staffed? Like, do you have
Yes,
the proper professionals, the midwives, the pediatricians,
yes, yes, yes.
obstetricians like
Well,
yourself,
I would say that because
nurses?
we have some knowledge about the disease. We're able to triage some of the cases to see, yes, this could actually be, even before diagnoses are made. We could say, yeah, this looks like this looks like Lassa, this looks like yellow fever, this looks like dengue fever. Then we have what we call a holding area. We have to temporarily hold the woman down pending when results are available. Usually, when you do polymerase chain reaction for diagnosis, within 24 hours, we're able to get our results and we read them. We confirm whether the woman is positive or negative, and then we now continue with other line of care. While we are triaging this patient, we usually give them what we call supportive care. The definitive care starts when we're able to make a final diagnosis.
Hmm.
So
Interesting.
that is why we actually work as a reference center for diagnosis, for research, and for management of these emerging and re-emerging infectious diseases. But I must tell you, over time, we have done a couple of work on pregnant women. I've worked with Professor Okoeguale, Professor Efeji, the current CMD, on a couple of projects in pregnant women. And I can tell you, most of the major publications in this field, particularly Lassa fever, have been from Area Specialist Teaching Hospital, from
Interesting.
seroepidemiology studies. Uh,
Interesting. Wow. So, like,
yes,
because you are actually, leading into the next question that I had for you, which is, your contributions to like over 50 papers, in this emerging infectious diseases field, right? It has no doubt enriched, the understanding of these threats, right? But then, like, what are the key findings from these research, right, that have significant implications on public health? Like, just, bullet points. What are those significant, findings that you have that you think the public should be well aware of?
All right. First, I will say that common clinical finding for pregnant women as it differs from the non-pregnant population. From basic research, just from simple observational studies, I would take Lassa fever as a point of call. When Professor Okoeguale looked at a couple of cases, over 40 cases, he noticed, I worked with him, I will notice very unique findings, some findings that are very unique in pregnant patients. First was the peculiarities in presentation. We noticed that during outbreak, you just see women coming with unexplained pregnancy losses. A woman comes to you, you just had a spontaneous abortion. You are thinking this could be a usual abortion, a common gynecological abortion, but the woman has had Lassa. Lassa fever is a common cause of first pregnancy and first trimester pregnancy losses. Within 8 months of being pregnant, within eight weeks of being pregnant, within 12 weeks of being pregnant, the woman loses that pregnancy, she's having fever and loses a pregnancy. You start thinking, what could have been responsible for this? In facilities where there are no materials to make diagnosis, some of them can be misdiagnosed. And that's why in some areas where some of these facilities for diagnosis are deficient, some cases have been misdiagnosed. And the Lassa fever has been a hidden cause of maternal death in some communities. So we are beginning to tell people these are peculiar signs, unexplained fetal loss. You don't know what is killing the baby and the baby just died. The fetus just died in utero. Either early in pregnancy or late pregnancy death from a woman who just had fever. You must make that, you must, try and do a Lassa PCR. The second thing is some of the breast finding that we saw. A pregnant woman having fever, the breast becoming so swollen, shiny, and painful. Some of the things we saw it in a couple of patients who later became positive when we tested them. We are now educating people, this is what happens. And then you do urinalysis. She's not hypertensive, because in pre-eclamptic patient like you have for usual obstetric patient, you are going to have proteinuria. When you do urinalysis, you see protein in urine, you see blood in urine. But these people, they don't have a high blood pressure. But you see them having protein in urine, you see them having microscopic hematuria, blood in urine. When you see them, even without having a PCR at that point, you must send their sample because the chances of them being positive is high. Then when we did seroepidemiology study, the last we did with Oxford, Northfield University, Oxford, we tried to check, how much of our pregnant women have actually been exposed to Lassa viral disease. We tried to check by taking their sample and checking for some of their antibodies. And we discovered that a couple of them, up to 45% of these patients, had an exposure. They actually had an antibody. Apart from that, we noticed that at some point, they tend to lose some of these antibodies, which means if there is, if we are taking that decision to vaccinate non-pregnant adults, we must also consider pregnant women as at-risk population. And whatever intervention we are giving to non-pregnant population, we must also find a way to apply. Look for products that are safe during pregnancy to apply for pregnant population because it's a large population. It's not a population you can actually leave out when you are doing some of these things you are doing for non-pregnant population. So they too has to be well protected.
Interesting.
Yes.
Wow. You seem to,
yes. Another group of
have
people.
done a lot of work on this thing.
Okay.
You seem to have done a lot of work on this thing, but then I'm looking at the fact that you have a meeting in, say, about 6 minutes from now. So I just want to run through the rest of questions that I have for you. Basically, like a 2-1 question, like, how do you get a balance, this busy life, intense life of medical research, right, with your personal life? And what advice do you have for young people for them to achieve success in anything they are chasing?
Well, it's difficult to strike this balance in Nigeria because first, we are having a lot of brain drain in Nigeria,
Yeah.
The
So
workforce
your advice
is
would be
draining
to join the brain
every
drain.
day. Is draining every day. So oftentimes you don't try to find that time for yourself. Try and keep your weekend as as calm as it can be, because definitely when you hit a Monday like this, your week is going to be busy. Yes. And then for my younger colleague, because I have a couple of people I try to mentor, I'm a lecturer at the Ambrose Ali University, and I have a couple of students that I teach. I have told them, to remain focused, just to try and live as simple as, they can. They can actually achieve anything they want to achieve if they work towards it, and also they should find a way, they can achieve whatever they want to achieve in Nigeria without necessarily have to travel seeking for greener pastures and all that. They can get to the zenith, develop themselves, and get to a very high, with very high potential, and still get the best for themselves and their family in Nigeria. Because a couple of things are here. And if you focus that
Okay.
energy and actually try to develop yourself around what we have on ground, you can actually do more for the community, have a satisfying workspace, have a satisfying practice, and still be happy with yourself, even while helping the community. So we need more people to stay behind
Okay.
and work with us.
Oh wow, I feel attacked now. I feel attacked because I'm one of those people that refuse to
We
stay
just have
behind.
to encourage them to stay, because it's becoming alarming. A couple of people are leaving, so we try as much as possible to find a way to encourage them to try and stay. They can actually do a couple of things. They can still work with organizations, outside this country, and still get the best,
Okay.
from it. So a couple of things they can actually do, and while
Yeah.
still helping the community, helping their families, and then, helping ourselves, so that we can maintain some level of, health workforce needed to, carry on with some of these things that we are doing in Nigeria.
Country. Interesting. So at the end of the podcast, we have a tradition, right? Usually we have a question from the previous guest, and then the current guest gets to leave a question for the next guest. So the question from the previous guest is, what is the best advice you have ever received from someone in the course of your journey in life? So what's the best advice somebody has ever given you?
I'm going to get a couple of advice. That's the best advice I've ever gotten. But I have to be focused, and do what I think is best, for me, and what is also going to satisfy my own being and my conscience.
Mm,
That's actually what I get a couple of times.
mm, Interesting. So what question would you like to leave for the next guest? Any general question for the person. Let the person have their work cut out for them.
Well,
What
I
question?
just want you to bring in more medical people into the podcast. Um, I appreciate what
Okay,
you people are doing.
you can recommend
I
some of
try
your
to go
colleagues.
through. Yes, I tried to go through your previous podcast. I'll be going through the page, which was sent to me, but at some point I tried to go through a couple of them, and I discovered that your focus wasn't really on this field of medical practice, and I think you should
Definitely,
bring in
and
more
what
medical guests to the field.
yeah, what more
To the
people
field.
from that, right? So the idea basically is you have professionals and entrepreneurs, right? So medical
Yeah,
professionals
yeah.
highly appreciated by me, right? So I want to have more people. So kindly send my regards to your colleagues, and refer them to come share their stories on the podcast. So before you did okay, you wanted to escape my question, but then I'm not allowing. I'm not letting you off the hook. What question would you
All
leave
right.
for the
Okay.
next question? And who would you
All
like to
right.
shout out? Yeah,
Oh, do you mean? How do you mean? Please, just
like
can you
like
repeat that again?
like I was saying that what kind of question would
Okay.
you like
What
to leave for
question for
the
the
next
next
question?
person? All
Yes. What
right.
question?
Okay. Okay. Just some suggestions about keeping more improving the medical workforce, keeping more medical workforce. What can we do better? to increase the medical workforce in Nigeria? That's actually my question. What can we do better to
Okay.
increase the medical workforce in Nigeria?
Medical workforce. Okay, interesting,
Brain drain is
interesting.
actually a major challenge, and I think about it
Wow, let's
because
look at that
would
concept.
yes, it's a major thing I think about because you train a couple of people this year, and next year you are losing over 75% of the people you have trained. Are there things we could do better locally? Locally within ourselves to keep some of these people within, to work within our community so that we can begin to develop that workforce or improve or increase the work because we need them. We need them to prepare for what is going to come. We don't know what is going to come tomorrow. We don't know if we're going to have more potential pathogens that is even more severe than these ones we are currently trying to tackle, Lassa fever, Ebola, Marburg, and all that. So we need to build critical mass that we can train in all fields of infectious disease are technical experts. We can't train some today and tomorrow we are losing over 75% of them. It's certainly not encouraging. We have tried to do something, but what else can we actually do to keep them on the ground
Wow, interesting. Wow.
locally?
Wow. I am really time conscious and I see that it's time already for your next meeting. So I want to
Thank
say
you
a
very much.
very, very big thank you, sir, for finding time to share with us on the podcast today. Hope to see your colleagues soon. Thank you very much. God bless you. Wishing you the very, very best in all of your endeavors. For me, it's bye.
Okay.